Okay, so tonight is Wednesday night the 12th, and I'm going to do a quick run through of some slides. Um, we're covering a couple of different topics tonight, chapters 5, which is hospitals, and uh, or ambulatory care, rather, and then chapter 8, which is finance. So we'll run through that fairly quickly. Um, Try to keep this an hour or so. So ambulatory care really is defined as any form of care that doesn't require overnight hospitalization. Technically, that includes every time you go into your doctor's office for an appointment. That's ambulatory care. So ambulatory care has been a major part of medical care basically always. Um, but ambulatory care has been growing with changes in technology and improvements in safety of treatments and everything else, and with payer incentives to decrease hospital stays, which are very expensive. So what we have is number of visits in ambulatory care are just skyrocketing, and by the ambulatory care, I include some of the more recent forms. So hospitals did a lot of care for a long time for a lot of complicated things, anything involving surgery, cancer treatments, imaging, etc., dialysis, many other procedures used to be taken care of in hospitals. Now many of them being done in private medical practice, ambulatory. Hospital emergency services are also ambulatory unless the patient gets admitted, and freestanding facilities such as freestanding surgery centers, freestanding ERs. Basically, these are not hospital-based, even though many of them are owned by hospital corporations. Private medical office practices are still the predominant way patients are seen, we need to look back at what created the current structure, which is mainly group practices. There are very few private sole practitioners left in medicine. It's just very expensive. This was pushed starting in the 30s and then was fought. The group health care establishment of group health insurance caused huge amounts of problems within the medical system and within the medical profession. It took really lawsuits and economic changes before these things stopped. The medical profession was actually sued quite successfully for at basically trying to interfere with commerce on treating patients. So there was a lot of trouble. A lot of times group practices were denied the rights to have hospital privileges. But that started changing, and especially it changed from during the time that Medicare started to appear and medical specialization started appearing. The costs of running an office from a technology and overheads standpoint also spawned opportunities for group practices to cut the average cost for the physician. Group practices can be a single type of practice. We take a look at places like ophthalmology clinics, where that's what they are, ophthalmologist only, an optometrist. That's all they do is eyes, to things like associates in family medicine here in the Fort Collins Loveland area, which is a multi-specialty practice with people that are generalists, geriatric specialists, cardiologists, endocrinologists, et cetera, all of these things. And they, that allows them a lot of freedom because they can generally get coverage if they need to go on a vacation or if they have a family emergency. And they can also reduce the number of support personnel required per person because they share all those. We've seen increases in physicians directly employed by hospitals as well. We talked about that on Monday. Hospitals see an advantage to that. You can be paging through the PowerPoint while you're listening to this. We have all sorts of other types of organizations that are looking at ways to improve the problem with fragmentation of services. The patient-centered medical home really is something it's a team-based model, and you have a linkage, basically a team of the various specialties you might need, therapists, nurses, etc., physicians, and other types of professionals for a lot of different aspects of care. A lot of this is supported by the Affordable Care Act. It is changing. People are really seeing this as changing the culture of medicine. There are payment reforms and then people that work together. We have the Accountable Care Organization, which is basically a group of providers that take care of the patient, and the personal care medical home is a component of that. An ACO, or an Accountable Care Organization, is a legal entity, and it has been working out and leads to a number of different results here, and a number of different advantages to the patients, and also reduced costs. They have arrangements with other organizations, hospitals, etc., to provide the appropriate care. The ambulatory care also includes a wide range of professional people who are not generally part of the regular medical team: dentists, podiatrists, PTs, nutritionists, etc. Hospital ambulatory care was often not very good. In the 19th century, it was trying to figure out what it was, you didn't necessarily get good physicians. Teaching hospitals and clinics were established. The 1980s saw the appearance of primary care as a core specialty, or a core part of medicine, and with a primary care physician sort of overlooking things. The ambulatory care in the hospital situation today is actually quite well advanced. It's well equipped. It's well staffed. It can be quite profitable for the hospitals. There are challenges, of course, and we still have patients that are seeing professionals across a multitude of clinical settings. Emergency services. Again, emergency services are a part of hospital. They usually are expensive because the emergency services need to be, an emergency room in a hospital needs to be able to deal with everything from a life-threatening gunshot wound to a woman going into premature labor. And there are, millions of visits. Most of them do not end up in hospital admissions. But we have, although it is set up for life-threatening illness and injury, and has lots of physicians and nurses, they're also seeing a lot of non-emergency conditions. There's a lot of inappropriate use. Although the percentage is small, it's still at least 10 million non-urgent visits. Freestanding facilities are often owned and operated by hospitals themselves. They're cheaper to run. Physician groups, some of them are for-profit, some not-for-profit, some part of corporate chains. They provide urgent care, which basically is the part of care that you need to get seen right away. Say your child is throwing up continually, you go in. We have retail clinics. These will appear in places even like King Super, certainly Walgreens, where you can go in and get physician advice, usually from a nurse practitioner. We have ambulatory surgery centers. You go in and you have a surgical procedure done. A good example is almost all cataract surgery now is ambulatory. You go in the morning or whenever you go in, you're prepped, you have the cataract surgery, you're driven home. So you don't stay in. They keep you only long enough to know that you're not reacting badly to the procedure, and then they send you out. We have public health services, and we have various other kinds of health centers. Urgent care centers began to appear in the 70s. They see a lot of visits every year. They have some primary care physicians. They have other services like labs and radiology. After hours care is available. Most areas that have any population will have a 24-hour, at least one 24-hour freestanding urgent care center, which we do here. The issue is that a lot of there are some contentious issues, and these involve making certain that the hospital emergency departments get to deal with the poorest, the people who can't pay, and hospitals will make sure that they get the ones who can. From one side, the physicians actually interfere in some ways with the relationship with your primary physician, and interfere with the continuity of care. But from the consumer, they get more response. If you go into an ER, you might sit for hours before you get seen for say a simple fracture. And whereas you go into an urgent care center, you're likely seen very quickly. Retail clinics we've started seeing just literally in the 21st century, and it can be done through a number of different settings. I had a student in HCA 474 actually working in one, and she wrote her report on how the one at the King Supers that she was working was organized and how it got started. It was a very interesting report. The insurers take it because they're cheaper, and often they will either waive or lower their copays rather. And so, they've been really working to expand these. There are some issues, as you might expect, a little bit of conflict of interest. For one thing, if you go into a Walgreens clinic, you're right there in a drugstore, so it sort of pushes you to fill your prescription right there. So there's, again, it gets in the way of the primary physician-patient relationship. But the problem, of course, is that you don't necessarily plan to get violently ill at 3 o'clock in the morning. Ambulatory surgery centers have been around for 50 years, almost 45 or so, 50 years. Advances in anesthesia have really driven this. It's made it possible, and surgical techniques, new operative technologies like laparoscopic procedures and so forth, have really made it possible to go in and have a procedure done and then walk out the same day. So hospital, if we look at the trends in ambulatory surgery visits, hospitals have been flat since the mid-1990s, whereas freestanding facilities have really risen about threefold. So ambulatory surgery centers, most of them are owned fully or partly by physicians. A lot of them, a quarter of them or so, have some sort of hospital ownership interest. It's in partnership with a physician, so the physician gets to run it. So, and then a very small proportion are actually fully owned. Medicare and private insurance mandates really have looked at this because they're cheaper. And hospitals have the opportunity to convert space that otherwise would be not used, and space is expensive. So there's lots of benefits. Access for patients, quicker recovery. They're accredited by most states. Federally qualified community health centers, we have them everywhere. There's a lot of those in the country. Again, there's a lot here. They do a lot of women, infants, and children, and do social work, public assistance. Many, unfortunately, of these patients are uninsured or Medicaid, so there's a cost issue. Unfortunately, what we're seeing in terms of Medicaid reimbursement rates have been dropping significantly, while the number of patients has also been rising significantly. So there's a squeeze put on the ability to do this. We'll keep going. Public health services grew out of the almshouses, poor houses, and pest houses we talked about on Monday, and really started developing with state-supported departments of health. And public health is very much interested in controlling the incidence of childhood disease and communicable disease, with one of the largest public health agencies in the world being the Centers for Disease Control. Lots of other services include immunization, screening, education, etc., staffed by all sorts of people, people working as physicians, nurses, support staff, community health, social workers, etc. We've got the most common ambulatory services include childhood immunizations, TB treatments, sexually transmitted infectious disease treatments, and family planning. The 2001's terrorist attacks prompted the states to strengthen, spend a lot of money strengthening infrastructure, but with so many new demands and other things, didn't do really much to advance it. Then about 8-9 years ago, we had the H1N1 pandemic, and the sort of panicked response to that, which didn't really turn into anything big, really. Not-for-profit agencies exist. They're usually run by volunteer boards. There may or may not have people that are mainly volunteers work. Excuse me. So the future expansion and work will see some changes. With our $3.2 trillion healthcare budget in this country and the outcomes we have, something has to be done to improve things. So that's the end of that. Now we've gone on to Chapter 8, financing. I'm going to try and quickly go through this as well. The financing of healthcare is a challenge. A lot of coverage is provided by private insurance. Some is provided by public funding, Medicare, Medicaid. Some of it is financed by out-of-pocket payments by patients. We have seen a lot of changes in the number of insured. Uninsured numbers have been decreasing under the ACA. This figure here is they haven't decreased by 1 million, they've increased by more like 25 million. The influence on financing are controlled by many factors, not the least of which is sheer politics. There's a lot of tension, and there's always a fight over the value of paying for healthcare. Most of us would agree that it's useful to have a healthy workforce, but who's going to pay for it? Also, we have seen an inflation rate in healthcare that is just very much in excess of inflation in the society. The number here of $2.7 trillion in 2011 is more like $3.25 trillion now, the last couple of years. We can look at these numbers. We can see where the payments are going. We've split it out into two different pie charts, one of which takes the ubiquitous other and then pulls that out as well. The home health care is part of other, but it's also a rapidly growing area. The private sources, private health insurance, Medicare, here's basically a distribution of the funding, with public sources responsible for about 40% of the total payments. And that figure probably hasn't changed much. If we look at, again, the calendar year 2011, we see that health insurance was responsible for 73% of the payments, out of pocket 11, other kinds of delivery, and then investment. Investment really means people putting money into investing in delivery services for ultimately to reap a profit. If we look at the health insurance, we've got Medicare, private health insurance. Okay, so 1/3 of the 73%, or approximately 24% of the expenditures actually come from private health insurance. 21% of that 73% are Medicare. Title 19 federal Medicaid payments represent 9%, state and local 6%, and then other programs like the VA, the Department of Defense, and Children's Health Program, and Title 21 are a small portion of it again. The U.S. has the largest percentage of the economy devoted to health, but lower life expectancy, poorer health outcomes. So higher prices do not necessarily lead to superior quality. Other nations will have universal coverage, while public funds only cover about 26% of our nation's people. Other nations use health services with more technology. Here's a statement. 20 to 40% of the spending is waste, which means services of no value, or valuable services not being efficiently delivered. And we need to look at that. Fraud and abuse are huge, 3 to 10% of the total spending. And we say 3 to 10% for the simple reason that much of it goes undiscovered. But when we do really investigate, we find that it's actually quite extensive. Specialty care is a lot of it. 60 or more % of the physicians are specialists as opposed to generalists. Our aging population is with increasing longevity. They're the major consumers. Drivers of the expenditures: labor, reimbursement and system incentives, and other ways of driving it. The evolution of private health insurance we've talked about before. Some started in the 1800s in movements to insure workers against lost wages from injuries, and then during the Great Depression, we saw the appearance of hospital of insurance. The insurance was not really to guard against things as much as to pay for routine or unexpected things. So the idea of the cost, but basically, whatever the billing was, there was no control, and the appearance of Medicare really ramped that up. Now we have government controls through the prospective payment and managed care payments and stuff. We won't talk about that. The history of insurance in this country is a real mixed bag. There was a lot of just insurance where the insurers paid physicians who would accept their rates. We had the concept of usual, customary, and reasonable fees introduced until the 70s, with the appearance of health maintenance organizations, specifically Kaiser Permanente Foundation. We also saw changes there in the idea being to try and keep people well rather than fix them after they're broken. That has always been something that's been an ideal of medicine that has a minimal real penetration until recently, and many people were able to recognize that they need to prevent illness rather than treat it. Unfortunately, medical education still revolves around treating payments. Managed care organizations, They use basically you pay your you use a set prepayment for a population of patients, and then a capitation on the amount that that is paid to providers per month, whether or not services are used. The leading to the temptation to profit off this. Lots of others, private health insurance as opposed to group health insurance has appeared. We do have plans. We can buy them now. Every state has a series of plans that you can get that have structures of copays and out-of-pocket maximums and you know, deductibles and so forth of a varying level. So we have point of service plans. Basically, you have a network of providers, but you can go outside that network and pay more. PPOs, preferred provider organizations, basically you have a list of people that are the preferred providers in your area that you go to. This covers quite a few people. The various programs have been tried. PPOs have become more common. We try not to have. We try to look at disease management as opposed to treatment, using again scientific data, evidence-based. Backlash. There are many restrictive practices to these managed care organizations, limiting who you can see, arguing about what kinds of procedures or drugs or whatever will be paid for. Many problems with that. We have seen inflation in the market, even under the prospective payment, which is the DRG stuff. They may have sort of slowed things down for a while, but the rate of inflation is still significantly above that of the general economy. There's all sorts of accreditation plans and services that are online. That basically that publish and look and provide quality indicators for providers and systems. This has resulted actually in people becoming aware that they have to really provide better service. Some of these are much more important than others. We're still working on the quality indices for physicians. I've seen some things you can get ratings for the physicians from patients and from their outcome reports. Healthcare effectiveness data is part of this. We look at the access and availability, satisfaction by the patient, stability of the plan, costs, basically the entire range of services. Self-funded programs. Large employers will collect premiums and pool the funds to pay for medical claims instead of using a commercial carrier. This is something that, again, you have to be a large employer. You're going to have thousands and thousands of employees for this to work. But there's also a tremendous overhead of running this sort of thing. Where did that go? Darn. Here we go. Back down to this. Look up something right quick here. I've drawn a mental blank. Yeah. For the employer, they don't have to apply it for Employee Retirement Income and Security Act, meaning that you're only insured while you're working for them. So there are some controversies surrounding that. There's still some work going on, and these plans have some legal immunity, which is unfortunate for withholding insurance coverage or for failing to provide care. That wasn't the purpose of them in the first place. The government as a source of payment, as it says here, a system in name only, used to be just the military, certain government employees, not all of them, and some special populations such as Native Americans would have their own medical service. Now we have Medicare and Medicaid, the public health service, we have veterans, the VA, et cetera, working with the as governmental sources of payment. It is a mess. There's a lot of different providers, and the programs are not really a universal system. They're for limited people. Medicare appeared in the mid 60s. Anyone over 65 goes on Medicare automatically. It's financed by payroll taxes. You pay part of it, and your employer pays part, which is why when you're self-employed, you pay double. The accreditation is through the private sector, through the Joint Commission. Hi there. Part A is the mandatory part. You go on at 65, you have hospital coverage, outpatient diagnostics, some home care, extended care facilities, and it's funded by the Medicare portion of your Social Security payroll taxes. Part B is theoretically voluntary, but if you don't take it and you decide to take it later, you get to pay more. It's basically pays 80%. You get to be responsible for the other 20. So what it has done is actually created an opportunity to acquire a plan to take care of most of the remaining costs. Part D, the prescription drug coverage, wasn't added until 2003. The idea with Medicare was to make sure that more people had necessary medical insurance. Problem is the cost just skyrocketed. And has caused lots of problems. We've tried to amend it to reduce the growth in cost, but it's still going up until they started reducing the actual payments. This is, to my mind, probably not the way they should have gone, but that's how they chose to do it. They should have been looking more at changing medical care so that we wouldn't have to pay as much because people were healthier. A number of cost containment acts have been enacted. Some of those involve reducing payments to physicians under Medicare and Medicaid to the point where physicians just won't take new patients. And when that's going to be a problem, I don't know. DRGs appeared in the 80s and shifted it from a preset hospital reimbursement based on diagnoses according to the International Classification of Diseases codes, ICD codes. We're up to ICD-10 now. They theoretically were to reward efficient care and penalize inefficiency, so insurers followed that too. It slowed cost growth. There was no real negative effect on patient outcomes. And hospitals actually saw a profit increase. COBRA, the Continuation of Benefits Act, came into existence and shortly thereafter, and really provided for some safety for patients. Physician fees have seen huge rises in Medicare, but late 80s price freezes were tried, didn't work. The results basically were offset by an increase in volume. In 92, the payments were stabilized for specialist or primary physician and made identical. That was a way to try and do that. During the debate during the Clinton years about their National Health Security Act, a number of things got established still. The medical savings account, MSAs, appeared so that you could put away money on a tax-free basis and take it out and use it for your medical care. The number of other attempts to fund children's the Child Health Insurance Program, CHIP, and reduce Medicare spending growth rate through cost reductions, both direct and indirect, and efforts to combat fraud. There was an attempt in 1999 to restore some of those cuts. However, there was a tremendous pushback on that. It finally did happen eventually, but we've also been seeing lately further cuts. There have been further efforts through the CMS to further reduce all these things. There are ways of looking. There's a hospital compare website so that you can actually find ways to to assess the quality of any hospital in your area. In 2008, so this is during the George W. Bush era, hospitals were not going to be reimbursed for treatment of hospital acquired infections or a list of what they call never happen events and higher treatment costs. Never happen events are like catheter acquired infections, foreign objects left in surgery, falls, and other trauma during hospitalization. The state Children's Health Insurance Program has seen a lot of growth and covers an awful lot of low-income families and children. The idea is to keep our children and not only healthier, but also to be sure that they are actually born healthier. There are many medicated services that are mandated. Funding is through income tax, corporate and excise taxes. Unlike Medicare, it's not an entitlement. You have to qualify in. If you do, you can then be treated. The reimbursement is direct to the physicians, to the providers, instead of through intermediaries like insurance companies. Again, it started growing rapidly, and as economics influenced, we had more and more people trying to become a part of it. The child health insurance program is currently a political football, and we'll see what happens to that. Quality initiatives to really try to improve Medicaid have been around for a while. The problem is that the healthcare has been a real issue. The reason we were able to obtain the Affordable Health Care Act is that that President Obama, during the election, made it a very priority in his health care in his election, and they took about 14 months to put this together, trying to really pull together a fully thought out plan that had buy-in from all of the various players. The financing provisions of the Affordable Health Care Act were quite a few. Americans had to carry health insurance or pay a penalty, except those that the cost would exceed 8% of their income, or with income falling below the federal tax filing requirement. There's religious exemptions. Undocumented aliens, those incarcerated, and members of Native American tribes. Undocumented immigrants generally don't buy insurance. Medicaid was expanded, and a large part of that was to be picked up by the states. Then the state participation was made voluntary by our Supreme Court. We have a variety of changes. We talked about health insurance exchanges as part of the health information technology discussion the other day. These are exchanges that are health insurance exchanges, rather, are a set of a web-based participation, so that consumers could have choices in both benefits and in pricing. There are some restrictions here. They have to be government entities or not-for-profit corporations. So we've taken a lot of overhead out. American citizens, legal immigrants, et cetera, are able to participate. And the penalties are supposed to help pay for the Affordable Health Care Act. Employers, they don't have a requirement to provide health insurance, but if they have more than 50 employees, they can be assessed $2,000 per full-time employee if they do not offer coverage. And at least one employee receives a premium credit through an HIE. If they do offer coverage, and at least one employee receives a premium credit through the health insurance exchange, there is an assessment the lesser of $3,000 for each premium credit receiver, or $2,000 per non-enrolled employee. Now, this means this has, of course, resulted in people reducing the number of full-time employees. So if there are other things, the high-cost health plans, and there are some, will have a tax. Increased Medicare taxes for high-income earners. So if we're on Medicare, we do pay a fee for our insurance every month. Lots of work going on and looking at how to make this work. So what I want you to do is read through the chapter, of course, do the homework for this week. There's a lot of information, lots of continuing challenges, and continued debate over the cost of healthcare and its outcomes in this country. And it's a continuing debate, as we've seen in recent years.